Welcome to Clinicals with PharmVic. Today I will be talking about acne vulgaris and its treatment. Acne vulgaris is a common skin disease caused by increased sebum production, abnormal follicular keratinization, proliferation of Cutibacterium, Propionibacterium, acnes, and inflammation. Management is directed at these factors. Start treatment early to prevent scarring and tailor according to severity. Mild acne consists mainly of comedones, open or closed with some papules and pustules. Moderate acne is characterized by more widespread papules and pustules. Mild scarring may occur. Severe acne consists of nodules, pseudocysts, and widespread papules and pustules. Extensive scarring may occur. Rationale for drug use: to improve complexion and reduce the number of lesions, to prevent scarring, or to limit disease duration, to reduce psychological stress, depression, and low self-esteem related to acne. When to refer: refer patients to a dermatologist if acne is severe or unresponsive to conventional treatment. For example, 12 weeks of oral antibacterials are unsuccessful. Any patient at risk of scarring, including a family history of acne scarring or in significant psychological distress, may also need referral. Acne conglobata, acne fulminans, and pyoderma facial are severe forms of inflammatory acne that require urgent referral to a dermatologist for treatment with isotretinoin and oral corticosteroids. Endocrine evaluation is indicated if signs of androgen excess are present. For example, hirsutism, androgenetic alopecia, and menstrual irregularities. Before starting treatment, consider and discuss the possibility of pregnancy before selecting treatment. Benzoyl peroxide, topical clindamycin, and oral erythromycin are safe to use. Although there are no data for azelaic acid, it is considered safe because absorption is low. Doxycycline is contraindicated after 18 weeks, 16 weeks post-conception, but is safe before this. Cyproterone, retinoids, topical and oral, and spironolactone are contraindicated. Choice of treatment: topical retinoids and benzoyl peroxide are used as first-line treatments in mild or moderate acne. If topical retinoids or benzoyl peroxide are poorly tolerated, azelaic acid may be used. When inflammation is present, topical clindamycin may be added for mild acne. Oral antibacterials may be added for moderate to severe acne. Isotretinoin is used for severe acne and for moderate acne unresponsive to the above treatments. Oral hormonal treatments may be added in females with moderate or severe acne. Topical retinoids. Topical retinoids are the treatment of choice for both comedonal and inflammatory acne. It may be used with other topical and oral antibacterial or hormonal treatments. Irritation may increase with use of one topical treatment. Do not use during pregnancy because of risk of teratogenicity. Benzoyl peroxide has antibacterial activity and is mildly comedolytic, useful in comedonal and mild inflammatory acne. It may be used with topical retinoids or topical or oral antibacterials. Azelaic acid has antibacterial activity and is comedolytic. It is a less irritating alternative to benzoyl peroxide in mild inflammatory acne. Use cautiously in patients with dark complexions, may cause hypopigmentation. Hypopigmentation effects may be useful if acne has caused hyperpigmented scars. Topical clindamycin. Clindamycin is an antibacterial and may have indirect effects on comedogenesis. Development of antibacterial resistance by skin flora is an increasing problem. Combination therapy with benzoyl peroxide or azelaic acid may reduce the risk of C. acnes resistance. Add topical clindamycin to a topical retinoid, benzoyl peroxide, or azelaic acid in mild inflammatory acne if necessary. Treatment should be changed if there is no response after 6 to 8 weeks. Stop topical clindamycin once inflammatory lesions resolve adequately. Limit treatment to 3 months where possible. Oral antibacterials. These are useful in treatment of moderate to severe inflammatory acne. Doxycycline is the drug of choice. Minocycline is second line as it has more adverse effects. esteem. Erythromycin may be used if tetracyclines are not tolerated or are contraindicated. Combine oral antibacterials with a topical retinoid and either benzoyl peroxide or azelaic acid. Change antibacterial or consider an alternative treatment if there is no response after 6 to 8 weeks. Limit treatment to 3 to 6 months when possible. Consider other treatment options if longer-term treatment is necessary. Oral hormonal treatments. These are limited to treatment of acne in females. They reduce sebum secretion, which is under androgen control. Several months of treatment are usually required before benefit occurs. Prolonged treatment is needed to maintain improvement. Estrogens suppress ovarian androgen production and are usually prescribed as the COC. All COCs are beneficial for acne. A systematic review showed little difference in their efficacy, but further comparative data are needed. Consider adding a COC to a topical retinoid, benzoyl peroxide, or azelaic acid in moderate acne, either in addition to or instead of an oral antibacterial. Cyproterone is an anti-androgen. Higher doses than are used in the COC are occasionally recommended by specialists, particularly if signs of androgenization, for example hirsutism, are present. Spironolactone has potent anti-androgen activity and has been used by specialists to treat severe acne. Isotretinoin. Isotretinoin acts primarily by reducing sebum secretion, used in severe acne or in moderate acne, responding poorly to other treatments. Prescription is restricted to dermatologists or other authorized medical practitioners. It is a known teratogen. Pregnancy should be avoided during treatment and for at least 1 month after stopping treatment. Other drug treatments include abrasive agents, for example, aluminium oxide, degreasing agents like triclosan, and preparations containing sulfur, salicylic acid, resorcinol, and allantoin. Although widely used, effectiveness is questionable. Exfoliants may limit tolerance to other more effective agents and have no effect on sebaceous gland activity. Counseling. Advise patients to do the following. Apply topical treatments to the entire affected area and not just to individual lesions. Wash affected areas gently. Avoid vigorous scrubbing and abrasive cleansers, which may cause more inflammation and make acne worse. Avoid using toners and oil-based moisturizers. Do not squeeze or pick the acne lesions, pimples, as this increases the risk of scarring. Eat a healthy, balanced diet. There is no relationship between particular foods and acne. Practice points. Do not switch or rotate antibacterials in patients who are responding to therapy. Response indicates efficacy, and changing antibacterials may promote resistance. Drugs for acne, retinoids for the skin. Examples include acitretin, isotretinoin. Other drugs for acne include adapalene, adapalene with benzoyl peroxide, tretinoin for the skin, clindamycin with tretinoin, trifarotene, clascoterone. This is a new drug. Unreported adverse effects or interactions may occur.